So right now there is a hollow cavern inside your skull that is actively excavating your face.
Yeah, it's literally growing larger by the year, hollowing out the bone behind your cheeks.
Right. And if the surgeon ever needs to break into this space, their margin of error before, permanently paralyzing your face or piercing your eye socket is roughly the width of a pencil eraser.
It is incredibly tight.
Welcome to the deep dive. Today's mission is to explore the hidden high-stakes architecture of the human face. We are looking at a clinical surgical guide written by Johann Fagan.
Right, which covers the Caldwell Luc procedure, antrostomies, and sinus punctures.
And reading this, it feels less like a dry medical manual and more like an intense map of the hidden cavern inside your own head.
Oh, absolutely. Because the precision required to navigate these spaces really reveals the dynamic, almost aggressive engineering of the human body.
Right, because we tend to think of the adult skull as just like a static shell of solid bone.
Yeah, exactly. But this surgical manual forces you to treat it as an active, shifting environment. You have to fully understand the bizarre nature of the space itself before you can grasp how a surgeon physically breaches it.
Well, let's start with that space. The manual focuses entirely on the maxillary sinus, which is the space sitting right behind your cheekbones.
And the text maps out its exact dimensions. It's about 25 to 35 millimeters wide and up to 45 millimeters long.
Holding an average volume of just 15 milliliters, which honestly doesn't sound like a lot.
It's not. And that 15 milliliter capacity dictates the fluid dynamics for literally every procedure in this guide.
Right.
Because when a surgeon is operating inside or flushing out that cavity, they are calculating volume and pressure based on that specific threshold.
So if they push too much fluid in there, what happens?
Well, pushing 30 milliliters of fluid into a 15 milliliter enclosed bony space without a clear exit pathway causes the internal pressure to spike violently against the surrounding anatomy.
Oh, wow. And considering the surrounding anatomy includes the incredibly thin bone separating the sinus from the brain and the eye, overpressurizing that void is a catastrophic scenario.
Exactly. It's an absolute nightmare. But the sheer volume isn't even the most surprising detail here.
No, it's the expansion. The guide highlights that the maxillary sinus expands at a rate of 2 to 3 millimeters per year until adulthood.
Yeah, the floor of the sinus undergoes this massive structural shift because of that expansion.
Wait, 2 to 3 millimeters a year? That adds up fast.
It really does. At birth, the floor of this cavity actually sits about 4 millimeters above the nasal floor.
Above it.
Right. But by the time a person reaches adulthood, that constant internal excavation drops the floor down to half a centimeter, even a full centimeter, below the nasal cavity.
So it basically operates like a basement that automatically digs itself deeper into the foundation of the house as you grow up.
That is a perfect analogy. The ceiling remains relatively fixed right under the eye, but the floor continually drops away year after year.
Which is wild. But because this expanding basement is completely enclosed inside the skull, accessing it has to be a nightmare.
Well, it is. There's one tiny natural exit called the ostium, which is located high up on the inner wall.
But if a patient comes in with a severe fracture or like a large tumor, that tiny exit is functionally useless.
Totally useless. You cannot fit tools through there for major trauma, and that leads directly to the surgical solution for those dramatic situations, which is the Caldwell Luc operation.
Right, the Caldwell Luc, which is basically knocking down the front door.
Yeah, that's exactly what it is. The objective is to breach the anterior wall of the maxilla, the front of the face, without leaving a visible scar on the cheek.
So how do they do that without leaving a scar?
They utilize the sublabial approach, which means going all the way up under the upper lip.
Ouch.
Yeah, they make a horizontal incision right through the gingival mucosa, cutting a line straight across the tissue from the lateral incisor over to the second molar.
Okay, wait, so they cut inside the mouth, above the teeth.
Exactly. But the mechanics of exposing the bone here are intense. Instead of cutting through the facial muscles with a blade, the surgeon uses a tool called a periosteal elevator.
Which is like a blunt-edged instrument?
Yes, it's blunt. They use it to slide underneath the periosteum, which is the tough fibrous membrane covering bone.
Oh, I see.
And they literally use this elevator to physically pry the soft tissues of the cheek upward and completely off the face of the maxilla.
Oh man. That operates on the same mechanical principle as sliding a metal scraper under tightly glued wallpaper to peel it away from drywall in one thick, solid sheet.
That's exactly the physical motion. It exposes the raw bone of the anterior maxilla.
Which the text says is highly contoured by the roots of the teeth running through it.
Right, and once they expose that bone, the surgeon is looking for a very specific target called the canine fossa.
The canine fossa. That's a natural depression in the bone just lateral to the mound of the canine tooth root, right?
Yes. The bone there is uniquely thin, which allows the surgeon to take a small surgical chisel, an osteotome, and literally use a mallet to break directly through that depression into the sinus cavity.
Wait, I have to push back on this.
Yeah.
Drilling or like hammering blindly through the face just above the teeth sounds like a massive risk to the structural integrity of the face.
It is a huge risk.
Right. Isn't there a danger of hitting some essential wiring or completely changing how a person looks?
You're absolutely right to question that. Applying blunt force with a mallet and chisel to the front of the maxilla deliberately compromises the load-bearing architecture of the face.
Obviously.
And that's exactly why modern surgical practice heavily restricts this approach. Historically, surgeons utilize the Caldwell Luc routinely just to strip out diseased mucosa for patients with chronic sinusitis.
Just for regular sinusitis, that seems extreme.
It was. But today, advanced flexible endoscopes can navigate through the natural nasal passages to treat basic disease. So this radical entry is now strictly reserved for scenarios where those endoscopic tools just lack the physical leverage required.
Okay, so situations like repairing major midface fractures or extracting large tumors.
Exactly. Or retrieving foreign bodies that have absolutely no business being inside a skull.
Right, the manual mentions some wild stuff, like pulling out lost dental roots that a dentist accidentally drove up through the bone during a botched extraction.
Yeah, that happens. Or even physically extracting bullets from the antrum.
Bullets, wow. So those trauma scenarios require wide direct visibility and the physical room to manipulate bone fragments or clamp onto large objects.
Right, you need the wide open front door, but knocking down that front door happens in an absolute anatomical minefield.
The nerves.
The nerves are everywhere. Just 5 millimeters below the orbital rim, so right under the eye socket, sits the inferior forenerve.
And that's where the infraorbital nerve exits, which feeds sensation to the cheek, the lower eyelid, the side of the nose, and the upper lip.
Exactly, and half a centimeter of clearance is practically zero in surgery.
Seriously.
The guide warns that simply peeling the soft tissue back with that periosteal elevator places dangerous traction on that nerve.
So if you pull it too hard.
If you stretch it too far with the retractor, the patient wakes up with a completely numb face for 4 to 6 weeks.
That is terrifying.
Yeah.
And the lower boundary is equally unforgiving. Right? The roots of the upper teeth basically dictate the inferior limit of the surgical window.
They do. If the surgeon angles the chisel even slightly too far downward, they slice directly into the superior alveolar nerves.
And those run horizontally right through the bone to innervate the upper teeth.
Right, so severing them during the entry completely cuts the hard wire into the jaw, guaranteeing permanent loss of sensation to the patient's teeth and gums.
Wow. So the entry window is totally trapped by the nerve above and the root system below.
Exactly. And this connects perfectly back to the active expansion of the sinus we discussed earlier.
Oh, right, because of the expanding basement concept.
Yes. That developmental timeline strictly dictates who can survive this geometry. The Caldwell Luc procedure is absolutely contraindicated in children under 7 years old.
Because their sinus floor hasn't dropped yet?
Exactly. The internal cavity is physically too small to operate inside.
And the unerupted adult teeth are still occupying that high jawbone.
Right. If a surgeon attempts to breach the canine fossa in, say, a 5-year-old, the chisel drives straight into the crowns of the permanent adult teeth before they've even erupted.
Ouch. So the body's developmental timeline effectively locks the surgeon out. The skull literally has to finish excavating the sinus cavity and lowering the adult teeth into their final position before there's enough safe real estate to drill through.
That's exactly it.
Okay, so the Caldwell Luc is this extreme mechanical solution for severe trauma. But what if the issue is just chronic pooling fluid or an acute infection?
Then the objective completely shifts from demolition to basic plumbing. You just need to drain the fluid.
And to understand that, we have to look at the body's natural plumbing system.
Right, which relies heavily on ciliated columnar epithelium. Basically, millions of microscopic hairs, called cilia, line the entire mucosal wall of the cavity.
And their entire biological imperative is to beat in the synchronized wave-like rhythm to propel mucus toward the natural exit.
Yes, but the critical geometric detail here is that the natural exit, the ostium, is located in the middle meatus, high up on the inner wall.
It's not at the bottom of the cavity.
No, it's not. So these microscopic cilia spend their entire lifetime sweeping heavy fluid upward, directly against the pull of gravity.
Wow, but when an infection thickens the mucus or inflammation swells the ostium shut, cut, that upward sweeping mechanism just stalls out.
Right, and fluid pools heavily at the floor of the sinus, creating this massive breeding ground for bacteria.
So for decades, the standard surgical intervention for this was the inferior meatal antrostomy, which makes total sense from a physics standpoint.
It does.
I mean, if you have a broken sump pump in a basement and fluid is pooling on the floor of a sealed room, you don't keep trying to push it up to a high window. You drill a drain hole at the lowest possible point.
Exactly. The surgeon punches through the thin bone under the inferior turbinate, creating a dependent drain right at the floor of the sinus. Gravity takes over, pulling the fluid through the new hole and out into the nasal cavity.
But Johann Fagen's guide points out a really profound limitation with this approach.
A huge limitation. The procedure actually has incredibly limited efficacy because cellular biology actively ignores physics.
Wait, really?
Yeah, the genetic programming of the cilia dictates that they must beat toward the natural osteum. They simply do not adapt to the new convenient gravity drain the surgeon just installed before.
So they sweep the mucus right past the surgical hole and stubbornly carry it upward to the blocked exit anyway. That is so wild. It's the biological equivalent of building a wide downward ramp for a colony of ants, only to watch them completely ignore it and continue hauling food up a vertical wall just because it's their hardwired ancestral route.
That's a brilliant way to picture it. And that biological stubbornness completely shifted the philosophy of modern sinus surgery.
Because you can't fight the cellular programming.
Right. Instead of punching new holes at the bottom, functional endoscopic sinus surgery now focuses entirely on widening and clearing the natural osteum at the top. You have to repair the original exit because the cilia will never alter their route.
Okay, but if permanent pendant drains fail because the cells ignore them, how do doctors manage an acute, life-threatening infection where they need to flush the sinus out right at the bedside?
That's where they utilize a sinus puncture. They bypass the plumbing entirely.
Right. The guide details two manual washout methods, the canine fossa puncture and the inferior needle puncture.
So the canine fossa puncture utilizes that same thin bone above the teeth we talked about earlier.
But instead of chisel, they use a trocar.
Right, yeah, a sharp trocar, which is basically a heavy-duty needle housed inside a hollow metal tube. They push it straight through the facial tissue and bone into the sinus cavity.
And the manual notes this external approach is specifically preferred for unconscious ICU patients or those with severe blood clotting disorders.
Yes, coagulopathy. And the mechanical advantage there is clear. If a patient cannot clot, a puncture through the front of the cheek allows the surgeon to apply direct external manual pressure against the maxilla to physically compress the tissue and stop the bleeding.
Which you obviously can't do if the puncture site is deep inside the nasal cavity.
Right, applying direct compression is physically impossible at the nose. But when surgeons do use that internal route, the inferior needle puncture, they are operating completely blind.
Which sounds terrifying.
They have to rely entirely on tactile feedback and a total mastery of spatial trajectory.
Because the inferior needle puncture involves sliding this curved trocar up the nostril, locking it under the inferior turbinate, and pushing it through the bone.
Yes, and the guide's instructions for executing this maneuver are intensely rigid. The surgeon must physically steady the back of the patient's head with their opposite hand to prevent any movement.
And then, here's the craziest part to me. They must precisely aim the trocar toward the tragus of the patient's ear before applying the force necessary to punch through the bone.
Aiming for the tragus, which is that small cartilage flap covering the ear canal, acts as a mandatory geometric block.
Why the ear, though?
Because the orbital floor, the bottom of the eye socket, hovers just millimeters above the maxillary sinus cavity. When the surgeon applies the forward pressure required to crack through the bone, there is a sudden release of resistance as the trocar breaches the sinus.
Like breaking through an eggshell.
Exactly. And if the surgeon's hand angles upward even a fraction of a degree during that sudden release, the sharp trocar slips straight through the thin bone of the sinus roof and penetrates directly into the patient's eye.
Wow. So aiming for the ear operates like a carpenter, utilizing a physical jig to keep a drill bit level. It forces the surgeon's trajectory into a strict horizontal plane, guaranteeing the needle travels parallel to the orbital floor rather than intersecting.
Exactly. It's a lifesaver. But the physical breach of the bone is only the first phase of the risk.
Right, because once the trocar is safely inside that 15 milliliter void, the surgeon removes the sharp inner core, leaves the hollow tube in place, and attaches a syringe to flush the cavity with saline.
And here's where the guide includes a bolded, critical warning. Surgeons must never insufflate the sinus with air.
Meaning they can't blow air into it to clear it out.
Never, because of the risk of a fatal air embolus.
Which is wild, because pushing an empty syringe of air into a closed bony cavity sounds relatively harmless until you actually map the vascular anatomy.
Right. If the sinus lining is severely infected, the microscopic venous channels within the bone become highly dilated and exposed.
So they're wide open.
Wide open. Forcing air into that enclosed 15 milliliter space rapidly spikes the internal pressure, and that sudden pressure forces an air bubble directly into those exposed venous channels.
Oh no.
And the venous system carries that bubble straight to the heart or the brain, triggering an immediate fatal embolism.
So a routine bedside flush to clear an infection carries literally lethal potential if the volume and pressure dynamics aren't perfectly managed.
It's a massive, massive risk.
The margins dictating every single one of these procedures are staggering. I mean, we are looking at a dynamic, actively expanding cavern that literally excavates itself deeper into the skull throughout childhood.
Yeah, and the Caldwell Luc procedure demands breaching the anterior face while threading a needle between the infraorbital nerve above and the superior alveolar nerves below.
Which remains anatomically impossible in young children purely because their uninterrupted teeth are blocking the door.
Exactly.
And then the internal drainage mechanisms highlight this fascinating, unyielding conflict between biological programming and surgical physics.
Right, where cilia stubbornly sweep mucus upward, completely ignoring the gravity drains surgeons attempt to provide.
Which ultimately forces surgeons into these blind, high-stakes punctures, where locking a horizontal trajectory toward the ear is